Good afternoon, everyone, and thank you for joining us today. My name is Tina DeWeese, and I'm the Customer Solutions Manager here with MORCARE. I would like to welcome you to our feature webinar today, Patient Safety, the Highest Priority. So today we have approximately 60 minutes scheduled. In the first 50 minutes, you will hear from my accomplished colleagues, Beth Brand and Dana Beaver-Lewis, on patient safety. Then we will follow up with time for Q&A, as well as discuss any ideas or comments you may have. Note, throughout the presentation, please feel free to type in a question at any time under the question drop-down field on the control panel. I believe you will see that at your bottom right. Or if your microphone is connected, you can use the raise your hand function. So today I'm pleased to introduce our speakers. We have Beth Brand. Beth is our Vice President of Product and Customer Solutions. A little history on Beth. She has over 30 years of invaluable experience in the healthcare industry. It ranges from critical care nursing, clinical informatics, and decision support to product expertise. At MORCARE, she provides leadership and guidance to both our customers and, of course, our MORCARE team. Prior to joining MORCARE, Beth was a longtime customer at Indiana University, where she was the Director of Clinical Decision Support for the health system. In this role, Beth also managed the IU team that was responsible for reporting and being analytics focused on quality and financial outcomes for clinical populations, physician services, hospital, and the health system as a whole. Additionally, we're joined by Dana Beaver-Lewis. Dana is our MORCARE Senior Clinical Solutions Consultant. Dana, for over 30 years, has led her career with care and compassion, immersing herself in helping others and organizations in the healthcare field. On the front line, Dana worked as a quality utilization review coordinator for over 15 years before making the leap to specializing in implementation. In 2004, she joined MORCARE as our Clinical Solutions Consultant. Her combination of hands-on service, along with her expertise in hospital quality, peer review, care management, utilization review, patient safety, risk management, and infection control are an added value when working with the client.
I started when I was 12 years old, by the way. Okay.
Okay. Well, thank you so much, Tina. And I apologize. I'm having technical difficulties here in my home office today. And try as I might, I had trouble getting the camera to work with the screen display. So I apologize. This is Beth Brand. And welcome, everyone. We realize that in healthcare, time is a very precious commodity, and we appreciate that you are sharing some of your time with us today. Our purpose in having this discussion is to share with you some of the insights that we've gained through working with our customers as we have assisted them in automating their patient safety programs and establishing strategies to measure the effectiveness of those programs. So this is just a peek at the agenda for today. We're going to start by setting a little bit of context around why risk management and patient safety are such imperatives within hospitals and healthcare settings. And then we're going to talk about how to find value in incident and event reporting. We're going to talk a little bit about the difference between reporting and analytics and how the patient safety has transitioned over into the world of analytics, and we're excited about that. We're going to talk about how important it is to provide actionable information in the course of patient safety event reporting, and then how to maximize incident reporting within your organization. And of course, we would love to hear questions and answers from you all. Well, to start out, who is MORCARE? We wanted to share with you a little bit. We are a healthcare software vendor, formerly known as Morrissey Associates. We have a 30-year history of providing exceptional products and solutions to healthcare customers across the United States. Our name was changed and we were acquired by Harris Healthcare in 2017, but the company has been in existence for quite a long time. We specialize in workflow automation across the care continuum, specifically for risk management and patient safety, quality management, and care management. And care management is everything from inpatient utilization review through discharge planning to outpatient care management and placement into appropriate services. One of our strengths is that we are a very scalable solution. We have our customers range from large national health systems to independent hospitals and hospital groups to very small independent critical access hospitals. And we have customers all across the United States. So regardless of the size or the complexion of the organization, we feel that we can be a good fit for you. And we also have had bidirectional interfaces with just about all the major EMRs in the country, everyone from Epic to Cerner, Allscripts, Meditech, MedHost, and there's probably others I'm not thinking of off the top of my head, but we pretty much can talk with anyone. We can receive information and send it back to just about any of the EMRs. So we're going to start here and ask you to stop for a moment and ask yourself just a few questions. What if your leadership could articulate the primary patient safety issues in your organization? What if you were confident that patient incidents were being reported and shared appropriately? And what if you had the information you need to improve patient safety in your organization? Well, we know that given the right solutions, these are all possible, and your organization can be empowered to make meaningful improvements in patient safety. So it's really difficult for those of us who've been working with patient safety and risk management for many years. It's really difficult to have a discussion about the importance of patient safety in healthcare and not reference the groundbreaking report To Err Is Human, which was published by the Institute of Medicine in 1999. And many of us were in healthcare at the time. I certainly was, and I remember very clearly when this kind of hit the presses. And it laid out a national agenda, really, for reducing errors in healthcare and improving patient safety. It was really kind of a loud and resounding call to action. Some of the findings that were shared at that time, which were just staggering to many of us, is that they identified that approximately 98,000 people in the United States die each year from medical errors. And at that point in time, medical errors were the 8th leading cause of death in the United States, which was really disheartening. And the total national costs of preventable adverse events were estimated at $29 billion a year. Their research was based primarily in a few focus states and then extrapolated for national application, but still those are pretty staggering numbers. And what they found was that adverse events occur in approximately 3% of all hospitalizations. The report went on to speak more specifically about the cost of these adverse events to hospitals and healthcare settings. And they, first of all, adverse drug events occur in as many as 2 out of every 100 admissions. And those alone increase the cost of the hospital stay by approximately $4,700. And these adverse drug events cost the nation approximately $2 billion, which is hard to imagine. But equally concerning are the opportunity costs involved, as testing and treatments for the impact to the patients, and then also extended length of stay following patient safety events. All of that is diverting care from other patients. But not all costs can be directly measured. We can't lose sight of how errors result in the loss of trust in our healthcare system by both families and patients. And in today's world of consumer-oriented healthcare, this can be extremely costly. To Err Is Human concluded that a comprehensive approach to improving patient safety was needed. There is no magic bullet that will solve this problem. And there were many recommendations that came out of that report. And just recently, I reviewed the report because it had been a couple years since I had looked at it. And those of you who are familiar with it, there are pages and pages of recommendations that came out of that report. But we're going to focus on just a few priorities that were stated there. Number one, the IOM called for incident reporting to be used by all hospitals as a very important means to achieve improvements in patient safety. And number two, according to the Institute of Medicine, the goal of reporting systems is to analyze the information they gather and identify ways to prevent future errors from occurring. In other words, the goal is not the data collection. Collecting reports and not doing anything with the information serves no useful purpose. Adequate resources and other support must be provided for analysis and response to critical issues. They called for a major shift in healthcare culture away from blaming and instead focusing efforts on learning from errors so as to prevent those in the future. And so what we have seen is that things have changed. Over the last 20 years, we definitely now see that the incident reporting systems have become a cornerstone in patient safety. It's definitely here to stay, right? And the advantages to incident reporting systems is that they provide structure and consistency in information reported versus, before lots of long handwritten narrative reports were submitted. These now are the electronic systems provide accessibility to all staff members, so everyone has access. It's much different from previous times when you had to obtain that manual incident report, and Lord knows where it was. These are easier to submit. They're therefore removing barriers to submission and encouraging reporting. They allow for easy retrieval and also referring to other departments, which broadens the perspectives and the context of the incidents. And then the information about the incidents and the lessons that are learned can be shared within the organization. So in all of these ways, incident reporting systems are contributing to improving our patient safety cultures. And we have seen, I think, a real shift in the culture. We've moved away from a blame-focused culture within patient safety. And I know that in almost all hospitals now that it's become the norm for staff of all roles to report observed incident. And now we're beginning to see that we're looking for system failures versus individual mistakes. However, having said that, contemporary healthcare does still struggle to realize its primary mission. While as an industry, we may have done a lot of work and we've performed a lot of research to improve patient safety, overall to date, we really haven't made the progress that we would have hoped. It's still now recent research as of just a year ago estimates that more than 1.5 million people are still sickened, injured, or killed by medication errors alone each year. And approximately 17% of all hospitalized patients are experiencing some sort of preventable harm. That seems so high to me, but that's what the research is showing. And that this is now the third leading cause of death in the United States. And what was staggering to me was to hear that more than 400,000 patients per year die from these injuries in the United States. And to put this in context, I looked up a few populations of a few well-known American cities. And do you know that 400,000 is approximately the census for Tampa, Florida, or Tulsa, Oklahoma? And that's the number of patients who are dying each year. So what we can all agree to is that underreporting of events remains a major issue. And some estimates are that 95% of adverse events go unreported. There's a real skewing in the reporting in that what tends to happen is the nursing and frontline caregivers tend to report more incidents. They are oriented more that way. And what that does is it kind of tends to impact the types of events that are being reported. Whereas a lot of major patient safety issues in our country today do involve physicians, and physicians are not nearly as prone to report adverse events. So that's something that we need to be addressing. But bottom line, patients today are experiencing 10 times the rate of preventable harm that they were 20 years ago. So this proves that while the industry may have done work and performed research to improve patient safety, it's made, unfortunately, not a lot of progress. Well, we all agree that change is needed. A culture of safety and reliability is really the only culture that is acceptable for our patients. However, it's apparent that we need to make some additional changes in order to achieve that. At this point in time, we have a real need for action. A lot of time is spent on patient safety reporting, but often that leaves little time for actual improvement. In many cases, a gap exists between that culture of safety that we all value and how health systems are actually using data to understand patient harm and what to do about it. We need to learn from what went wrong instead of just stating that something went wrong. We need to improve feedback mechanisms so that those who report are informed about the results. That will help keep them reporting, right? And often we see that data exists, but there's no follow through with improvement initiatives based upon that data. And we all know that if changes aren't implemented and recognized, the motivation to continue reporting will decrease. So patient safety improvement really centers on 3 actions. And as we consider how to make the changes that are needed, we need to really think about these 3 steps. Number 1, identify and describe the safety issue, or measure, collect and measure, right? Number 2, take action to help the patient, intervene, make changes. And number 3, that allows us to avoid similar events in the future. Prevent. That's all about, really, at the end of the day, preventing. So the question is, how can we modernize incident reporting systems so that they become a more effective tool for advancing patient safety today? For the purpose of today's discussion, we want to focus on 3 tactics that will assist in this effort. First of all, understand the events that are occurring and identify what the priorities should be for your organization. Not all events result in harm, but a priority should be to focus on those events that are causing harm to your patients. Also, we know that not all events are preventable. Accidents really do happen. So put the time and energy towards the preventable events. And share the priority list within your organization. Help your teams understand that as these priority items are resolved, the focus will shift to other priorities items. So being able to pivot and change according to what you're hearing and learning from those incident reports. So the second thing is to understand how patient safety improvements support value-based care. And as all of us on this session today probably understand all too well, that with the transition from fee-for-service to value-based reimbursement, the importance of patient safety extends beyond just patient welfare to increasingly impact the health system's financial bottom line. Reimbursement is now being tied to patient safety, and health systems that aren't engaged in driving down patient harm risk reduced reimbursement. And in addition, as we discussed earlier, providing safe patient care provides cost savings. Now is the time to show the value that risk management analytics can provide, putting the right information in front of the right people at the right time, empowering organizations to optimize patient outcomes and financial performance. Patient safety has always made sense as the right thing to do because it's based on caring and compassion. But now, by providing a business case, you will be able to support enhanced safety and demonstrate added value. So that leads us to calculating an ROI for risk management and patient safety programs. Traditionally, we think of ROI as how much money are we making on an investment or a technology. But equally important questions are, what can be done to reduce costs and improve care? A good place to start in that is to understand the cost of adverse events to your organization. And what you see here is a tool that was actually created by AHRQ, the Agency for Healthcare Research and Quality, designed to assist healthcare organizations in quantifying the cost of adverse events or healthcare acquired conditions. And what you'll see here is that AHRQ has listed some of the common healthcare acquired conditions or adverse events, and then they have given, based upon their research, an average cost per event. And in order to calculate how this impacts you and your organization, it's a matter of understanding the number of each of these event types that occur in your facility, and then multiplying by the average cost, and that's going to give you the average cost to your facility each year for these events. Now, we thought that it would be a good idea to show you an example of this. And so, in order to be completely conservative, in each case, we're going to take the lowest dollar amount in each of these ranges. Okay. And what we're going to show you is how, just for 3, we're just going to choose 3 of the most common adverse events. And we're going to, again, take the very lowest range that we showed before, provided by AHRQ. We also have here from the Institute of Medicine, a study that determined the average number of each of these events per 100 admissions. Again, this is nothing that we've concocted here. We're using the experts for this. And then what we thought would be interesting was to show you for different size facilities what the cost could be per year for these events. All right, so we start with a smaller facility that has on average about 2,500 admissions each year, and we apply this algorithm. What you'll see here reflected are the costs associated cost to the organization for these 3 adverse events. You see it adds up pretty quickly. A larger facility, 7,500 annual admissions, and you'll see here how quickly those numbers add up. And then for a larger facility, it's completely a matter of scale here, that as we increase the number of patients we see, we unfortunately are increasing on average those adverse events, which then drives up the cost. Okay. The ultimate purpose for collecting data is to provide a basis for action. This is actually a quote by W. Edwards Deming, one of my favorites. Those of you out there who work in performance improvement, process improvement in the hospitals, I know you're probably very familiar with Dr. Deming, but I love this quote of him because you know, it's all about why collect the data if we aren't going to use it to take action. And so what we see here is over the last 20 years, the focus on building incident reporting systems has led to our current problem with incident reporting. So what we have done is we are strong on data collection, but not nearly so strong on using the data. We collect too much and we do too little. As we have mentioned previously, in order to move forward and make progress with patient safety, we need to focus efforts on learning from the information and really be willing to consume that information and make change. For this is how we will truly be able to improve our patient safety systems. Okay, at this point, we have a very short poll, which we would ask you to take just a few seconds here to respond to. And I think, Andrea, are you going to be turning that poll on for our guests? If you could take just a brief moment to respond, we would really appreciate it. Okay. All right, thank you. Well, what enables us to understand where processes need to be improved, where we need to take action, is really the movement into analytics. At MORCARE, we have a number of interactive dashboards, which are extremely popular with our customers. My colleague Dana is now going to share with you how some of our customers utilize our risk management dashboards to support their patient safety programs. Dana, I think you're going to take it away.
Okay, yes, ma'am. I will make myself the presenter. And if you can just let me know once you see my screen, Beth.
Yes, we see it.
Okay, excellent. All right, well, thank you everyone for joining us today. And I am going to share with you how some of our customers are utilizing our dashboards. And down here, these are just some of our dashboards that we have here. They're out of the box, they're plug and play. It pulls in your data in an easy, readable format. So let's go ahead and let's go into the risk dashboard here. The first thing it wants me to identify, what date range do I want? I want to let you know I'm using dummy data here, so these date ranges are a little strange, but this is not real patient data, but it is geared off of real life situations that I have entered in myself as a case manager entering risk or identified from some of my customers. Okay. So immediately you can see my dashboard opens up, and based on those dates, I have a nice bird's eye view of all the problematic areas that I could possibly have available that's going on in my organization right now. The very top here lets me know how many incidents have been recorded during this time period currently as opposed to last year. And what happened during that time, and I can tell you, and again, this is a real life story, is that we had an organization where they implemented a web-based incident reporting system. And once they did that, they just had, well, you can see here almost a 70% increase in their incident reports. Okay, because this way the nurses and the techs felt very comfortable entering in an incident because it was an easy process to do at this point. Okay. So again, this is such a nice area to be able to see here. My incident date range, I'm able to modify my dates at any time by just using the slide format here, this tool that allows me to zero in on just the dates that I want to be able to look at. Over here to the right, I am going to choose my hospital because can be multi-facility. And I just want to look at just my hospital and see how we're doing overall. And I can see, wow, we're still doing pretty good with everything. Okay. The quadrants, this is showing me incident volumes by month, so I can look at any trends that might be happening. And again, just a sneak peek into what I'm going to go into is that you can see that we really dropped off on incidents here, and I'll talk about the process improvement initiatives that this organization put in place to make that happen. This quadrant identifies incidents by various groups. So again, these incidents are put into different groups, and then you can see those groups and what is the volume within those groups. And I love how we have this nice Pareto chart where I can see where I need to really focus my energies on. And here, of course, you always want to make sure you're capturing near misses. Down here, I'm able to look at any problematic areas where most of my incidents are happening. And I can see the majority are patient room. We have some emergency room issues and same day surgery. And of course, this last quadrant here are my severity levels. We want to see majority of our incidents have no harm. However, it's very nice to be able to see what incidents are causing major harm, death, or what have you. Okay, and you can zero in into that. So let's talk about how to utilize some of these filters. If I wanted to, again, just look at information for an employee or a patient or visitors, I can quickly do that as well. Okay, and the whole screen will morph based on that. Down here, incident group. I can choose which group I want to look at. And for today, we're going to look at some events that are more avoidable. So I'm going to choose medication and some adverse drug reactions. Okay, and we can be able to see how that's going to look. And look how my chart is immediately reformatting here. Okay. Severity level, I'll leave that at off right now, and location as well. I'll leave that at all because I can see that it looked like we just have this issue in a lot of our different areas here. Okay, so now let's go and focus on this area. So I have my adverse drug reactions. Now, in this example, those aren't necessarily all preventable, but you kind of want to go in and see what's been entered in on these, and is there a way that you can put in process improvement initiatives. So I'm going to go ahead and click on my adverse drug reactions, and there's 11. Beth, I think you might want to mute your phone. Hear a little bit of feedback. And then here, this is going to show me two separate charts here. One is showing me the delineation volumes, which tells me a little bit more about that adverse drug reaction. What happened to the patient? And, most of the time it is itchy skin, difficulty breathing, and then it has some more of the more extreme adverse reactions, which could be heart failure, renal failure, and so on and so forth. Down here is showing me any contributing factors, okay? Polypharmacy. Maybe the patient had a new allergy we didn't know about or they didn't know about. Unauthorized medications given by family. This is a true situation here. This happened in my family. My mom brought some medicine into my dad that he wasn't supposed to be on, and it caused a reaction. So again, it's nice to be able to have these things recorded so you can identify, again, what can we do to help to prevent some of these things from happening. Distractions and exhaustion of the staff, and a missed alert allergy. So again, this allows me to see what are the contributing factors, and these are things that I can maybe make a change to make some of these adverse drug reactions, which again, all of them aren't preventable, but you can prevent some of them. Okay, so if I go into this one, it's going to drill all the way down into the patient level. So I'm able to see exactly what patients were involved, what was the visit number. I can even look this up individually, okay? And I can again see the delineations and the contributing factors. And if you put any notes in here, you can review that as well. With all of our reports that I'm drilling down into, all of these can be exported in a PDF, an Excel, an RTF, and a CSV. So again, you could print this out and go and look right into the system or in your EMR and begin to do some of that investigation. Okay, now let's go back out. Now this time I'm going to go into just the medications here. And when I go into these medications, here I can go in here and I can now begin to see the delineations for these medications. Okay, or what happened with these. Tell me a little bit more about these. And I'm able to go in here and I'm able to say, okay, wrong medication given. That is a large amount right there. So with this, I can quickly go in and I can say, let me look at these. How many times are we given the wrong medication and what's going on? So this is one that I doctored up earlier. So I'm actually able to go here and see. Andrea, can you see if you can get this off of my screen, please? I don't know how to, why these are popping up. I'm trying to close the window and it says I am in a meeting. So I'm not sure why this is popping up. So this is showing me a nice area here again with information, and you want to make sure that your risk management system that you're currently using provides you with that. So this is all the information that was captured in for this incident. I can see the web-based incident reporter comments. Okay, this is one where the nurse is saying that she accidentally gave the wrong medication. She gave clonidine instead of Klonopin. And then it automatically went to 3 people, and it could have went to more. It went to the nurse manager. So then the nurse manager weighed in. The pharmacy director weighed in. And then, of course, finally, the risk manager weighed in. And we're able to see that progression as to everybody that they weighed in. What did we decide to do? And of course, here, they decide they're going to do a medication protocol refresher on 5 West. So this is where you can start making changes. Okay, another one here was wrong medication given. So again, being able to have this detailed information to go from a high level report all the way down to the patient details, that's just phenomenal. And it allows you again to make those changes that you need to make. Going out here, contributing factors, a very, very valuable thing. And one of the things I would like to mention as well, make sure that your risk system, that you're able to go in after you do your investigation and add additional contributing factors, additional delineations if that's necessary, because that will tell the whole story, okay? Procedures not followed, distractions, look alike, sound alike. So I'm sure all of us can look at these and possibly be able to know, hey, this is how we can make some changes. And what are some things that you can do? You can initiate post-event huddles. That would help out to find out, why aren't the procedures being followed? We can provide refresher training on each unit. You don't have to wait until it shows up on every unit. You can provide refresher training, say, this is what we did. Are you doing your root cause analysis to determine that if you have something where it was a look-alike, sound-alike, and that's truly the root cause, what can we do? Let's get with our pharmacy department, okay? We can relook at several different policies to see how we can make changes if they're not working for us. Okay, all within just a quick glance and a couple of changes here within the incident group, severity level, and within my chart here. Okay, now one of the things also I want to be able to share with you here is that I'm going to use my slide bar. This is where, and again, I have to do this, but in this scenario, what happened is that the person actually ran the initial data and they were running it all the way to I believe it was 6 months. I'll say 6 months here. And this is what they saw for their medications and their adverse drug reactions. It was just going up and up and up. Okay, they're trying to figure out how to make a change with this. Down here, they was able to see the emergency room, the patient room. There was a lot of drug errors happening on these particular floors. So then what did they do? They implemented some of the policies and procedures that I talked about, post-event huddles, refresher training, doing the RCAs, and then they ran the chart again. Now this time, let's take this all the way out and let's pull this in. And now let's look at see how the data looks. So imagine the second half of this. Wow, what a difference. And again, this does not affect the number of incidents that are being reported. This is showing an outcome of the changes that I've made or our organization has made with our policies and our procedures, our post-fall huddles, and all of that. Okay. I want to jump down here real quick, incident location. If you want to take a look at the incidents that are happening in save day surgery, it's going to open up to those particular groups as well. And then from the group, then it goes all the way down again, where you can look at the detailed report. So that's much show you how that drill down works. Okay. Over here, volume by severity. And let me just take these off of here. Let's just get a full list here. For the volumes by severity, what it's going to do is that as you click those, then it's also going to take you down to those particular cases that fall into that particular severity, but it's going to show you the groups first. What groups are these severities falling into? Which is a very important thing to be able to identify. Okay, I think I just lost my web page here for a second. Okay, let me just let this refresh a little bit. All right, so there we go. So now I can look at some of these. Let me take off that adverse group here. And now it's going to refresh and show me everything, all of my incidents for my particular hospital. And then from here, I'm able to go in and again, look at the ones that are major, look at death, look at moderate, look at minor. And it's going to open up again to the groups within those groups. So all my minor severities fell within these groups. I can go look at my falls again or my medications. Okay, so this is where you truly have your actionable data, being able to see data, to be able to make changes, to make a difference. And this is where a dashboard can help. You should clearly be able to see a difference after you initiate that. And that really helps your staff want to put in more incidents, to be honest, because they can see there has been a change. They're getting more training. Because like Beth mentioned, we live in a just culture now, so it's not about blame. It's about, identifying cases and find out how we can stop this from happening again to our patients. Okay. All right. Well, I hope you guys enjoyed that. And hopefully when we get to the question and answer section, you'll have some questions for me. So Beth, I'll send it right back over to you.
Thanks so much, Dana. That was great. And of course, one of my favorite things is looking at the dashboards and how to utilize the data.
Mm-hmm.
And so now we'll pick back up again here for a few minutes. So in summary, it's kind of a resounding theme here today, but in summary, what we're trying to communicate is that the search for safety really starts rather than ends with incident reports. Incident reports are very valuable, but it's really just the beginning of the process. And how can we help you? Well, it just so happens that we have some great solutions that we're very excited about and we would love to talk to you all about. We have web-based incident reporting tools which are easily configured by the customer, easy to submit incident reports, they're easy to change, you can customize those. And I was a customer, as was mentioned earlier, for many, many years, and we use these throughout our organization. And actually, every time there was a change in leadership or a change in focus in our patient safety risk management department, we could very quickly change our incident reporting tools and get those out there for people to utilize. We offer a couple of options. We have out-of-the-box AHRQ standard formatting built into all of our codes and our categories for incidents, so it's very standard with that national AHRQ format. Or you can define organization-specific workflows and use your own formats. It's really totally up to you all. But what we offer is an automated process which also provides, among many other things, immediate automated routing to the appropriate department managers. We spoke earlier about how important it is to make sure that when an incident occurs, that all of the managers involved are notified and can provide feedback and input. And it also provides visibility into the next step. So a risk manager can know at a glance who has responded with their comments on the particular event and who has not responded yet, and we can have automated alerts to go out to those people saying, hey, it's time to submit your comments on this incident. But the best and probably the most what we feel is really helpful are the dashboards and analytics. We can provide real-time actionable information with drill down to the patient level. You saw Dana take us through some of the paces there, and it's, imagine having that on your desktop every morning. It's just an invaluable tool, and it all just automatically feeds out of the incident reporting process in our solution. So at this point in time, I think I'm going to turn it back over to Ms. Tina, who's going to take your questions.
Opportunity to wish all of you on this call a happy National Hospital Week this week, and extend our gratitude for all that you do to keep us all healthy and safe. So we're going to open up the floor for questions. Just a quick reminder, please ask your questions by typing them in the questions feature now. I see a couple of them popping up in your lower right-hand side. You can also raise your hand and we will unmute you so that everyone can hear the question. So we're going to give you a few minutes here. One question I have is, will the slides be sent out after the webinar? Beth?
Sorry. Yes, we can certainly do that. Or what we can do is provide a link also to the recorded session. So happy to share.
Okay, thank you.
Mm-hmm.
Looks like another question here. You mentioned about high priority reporting. Do you recommend focusing on the highest number of incidents or potential preventative ones?
Oh, wow, that's a tough one, Beth. I'm going to jump in first, and you might want to weigh in. Those are two very good ones. I like to really go for the more of the low-hanging fruit and quick win. So I'm thinking if it is a preventable incident, then I know whatever processes improvements I make, then I will see an instant change from those. Sometimes if I'm just looking at like the overall falls, and it might be a lot of them, but a lot of them might be, the patient, just didn't wait until the call light was answered or whatever. So it's really up to your organization, but talk to your leadership and find out. But just remember, focusing on preventable ones is really a quick win for your organization and for your patients. So Beth, did you want to weigh in at all? Or?
The only thing, I definitely agree with you. The only thing I would say is also, of course, and I know you probably just assume this, but anything that's causing harm, look at, first of all, because a lot of accidents happen and there is no harm, thank goodness, right? And so let's focus on A, what's causing harm, and then B, what is preventable. Exactly.
Okay. I have a second question here. Can you review again the difference between reporting and analytics?
Okay, Beth, I'll take that one.
Yep, I'll take that. Well, they're both very, very important. And actually, you know, the lines do kind of blur because one could argue technically, from a technical standpoint, that an analytics dashboard is really comprised of a lot of different reports. So without getting too technical, I think that, you know, a static report it still has a lot of value in a lot of situations. And I can tell you, for example, when I worked for a large healthcare system and we utilized this solution for our patient safety programs, we did have some automated reports that just were distributed each morning out to specific leadership, reports about where, you know, any of our high severity incidents had occurred. And that was just, it was just sending some notices out and getting people's attention right away in the course of their other work. They wouldn't necessarily have been accessing and drilling in through a dashboard, but this is to catch their attention and again to just provide an update on certain standardized measures. And that's where I think reporting is still really, really important. But I am completely, having spent many years in decision support and analytics, the power and the robustness of being able to drill down and slice and dice. You know, those of us who work with data, you never know where you're going to end up when you start out. And it all kind of depends on where you click next and how you slice the data. And I think that it's very difficult to support that type of investigation through static reports. And so that's why I personally love analytics. It's like being detectives, and we're out there, you know, you start and it leads you to the next question and the next and the next. And what better to support that than a drillable analytics presentation.
Thank you. I have another question here. Where can I get the information to calculate my hospital ROI for risk management?
We would love to help you with that. So please, we would love to talk with you and just gather a little bit of information about your hospital volumes, and then we can apply this risk calculator and talk with you about what appears to be the average cost within your organization.
Okay, well, this is great. Lots of good questions. So another one, what suggestions do you have to help motivate my staff to enter patient safety events?
Dana?
Oh boy, yes, I'll take that one. One thing I can tell you is to keep pushing the just culture. Back when, like I mentioned, when I was 12 years old, working in the hospital as a utilization reviewer, that wasn't pushed. We didn't know about we know we were supposed to report things, but nowadays, you know, create posters, push out that just culture that, you know, we just want to be able to report out. There's no blame area, because that will help us learn and be able to take care of our patients as well as ourselves and our other staff members appropriately. The next thing is the ease in reporting. How long does it take them to put in an incident report? You know, it's a whole lot of pages. Is it very confusing? You want to look at that. Some software systems, they provide an out of the box, which we do too. Ours is our HRQ format. However, you can modify it or you can create your own. So whatever you need to be able to do, I even tell some people back in the days I would implement, if you have an incident report that all your clinicians are used to right now, make that electronic. You know, create that in your system, and that will allow for not only a learning curve, but the ease in reporting. And the last thing I've heard from my customers is the ability to be able to provide feedback. You know, if I'm entering all these incidents, I'm doing my, you know, due diligence, I want to be able to hear back as to, you know, what's happening with these? What changes have we made? And within our system, of course, we allow you to be able to do that. And if your system does not, you really want to push your organization to how can we provide feedback, because that's one of the things that's really going to engage my staff to report more. Okay.
Okay, we have another question. How long is your implementation of this program?
Beth? Take that one.
Well, that's a good question. And it really, not to dodge, but it really depends upon how much customization you want to do. And so there's no, just like we really don't have a cookie cutter approach, there's not a cookie cutter answer to that. Usually within 8 to 12 weeks, but it really, again, depends upon how quickly, we can understand your workflow and get those incident reporting tools built according to your specifications, and there you go. And then, of course, the size of the organization, how many facilities we have. When we roll out to our larger customers with multiple facilities, sometimes that takes a little bit longer, whereas a single facility is obviously a shorter implementation. So very sorry, don't mean to dodge, but it's really customized according to your setting.
Okay, I think I have one more question here.
Those are great questions. Thank you, everybody. We don't have a shy group.
No, we don't. Very nice. Very good. Very good. I believe we have a hand raised out there. I can see the hand raised, but I don't see the question.
Yeah, let's see. I see if there was a hand raised. If you see the hand raised, Tina, you can unmute them. Maybe they want to speak, but I think it was a mistake, though.
Okay. We'll give it another minute if there's any further questions.
Mm-hmm. Yeah, but great
While
question,
we're waiting,
everybody.
Yeah, absolutely. Good group. While we're waiting to see if there's any further questions, just so you know, at the end of our presentation, there is a survey that will pop up. We always appreciate the feedback. We're always looking for topics, ways that we might improve our webinar, so we appreciate your feedback. And whoever raised their hand, I think, put it back down on their desk. So just another second. Does anybody want to raise their hand? Okay. All right. Well, that concludes our webinar today. If there are no further questions, we do want to thank you for joining. We appreciate your time. We know it's hard to give up an hour of your time, and it is greatly appreciated. I have put up some contact information. You can reach out to Beth or myself. We always have upcoming webinars. We have our website located below, and we're always glad to also provide information one-on-one of our webinars. Beth, Dana, do you have anything else to add?
Nope, just thank you guys so much.
Yes, thank you guys very much for attending, and we hope to be talking with you soon.
Yeah, absolutely, thank you.